Absolutely. I'll start off my presentation here. I'm Brian Park, PGY4 with Navy, presenting on minimally invasive surgery and spine trauma. I have no disclosures. I'm a resident. A one day overview. Uh, so we'll go over what minimally invasive spine surgery is, history, epidemiology, classification, the rationale for minimally invasive surgery, and the application of it, downsides of minimally invasive surgery. We'll go over a case and then conclude. So, what is minimally invasive spine surgery? It's a preservation of soft tissue while maintaining principles of decompression, stabilization, and deformity correction. That summed it up pretty well. And it also minimizes surgical disruption to normal anatomy while effectively treating spine pathology. The history of minimally invasive spine surgery. This was a good chart. It's pretty extensive over all the advances in spine surgery and the approaches. I think mainly such as tubular retractors, fluoroscopic guidance, muscle sparing techniques for approaches. There's been a lot of technological advancements, mainly lighting, so illumination, magnification, and instrumentation, which has preceded this minimally invasive spine surgery. Uh, Reduced rates of complication, minimal soft tissue trauma, less blood, shorter hospital stays, and outpatient surgery feasibility with these technological advances and innovations in spine surgery. Epidemiology in terms of spine trauma, there's over 160,000 spine fractures that occur annually in the US. The vast majority of this is going to be in the thoracolumbar region. Accounts for more than 50% of the fractures that we see in terms of spine trauma. Obviously, high and low energy, whether it's a ground level fall, fragility fracture causing a compression slash burst fracture versus a high energy, such as a motor vehicle accident or falling from a um, high area. Spinal cord involvement is about 26% of these thoracolumbar fractures. And then a lot of these spine trauma patients, just like any sort of trauma center, they're going to have concomitant injuries. So many of these patients are polytrauma patients, which can be especially difficult in terms of managing their injuries. So we'll go into classification systems. I think we've gone over this extensively last week as well in Journal Club, but this is TLIC scoring. I think this is the most commonly used in terms of the classification systems that we have. It focuses on treatment decisions by assigning a numerical score based on the injury morphology, the neurologic status, and posterior ligamentous complex. The pictures there, you see the compression slash burst fractures, rotational fractures, and distraction type fractures in the A, B, and C up there. In terms of management and how it guides our management, you add up the points. 0 to 3 is non-operative. 4 is basically up to the surgeon, whether it's operative or non-operative on the fence, and then greater than 5 is operative. In terms of its strengths, it's very simple to use and widely adopted, as we talked about. And then weaknesses, this may not be as reliable as the AO spine classification because it doesn't have specific patient-specific modifiers. But again, a lot more simpler than the AO classification. Again, you can see the difference here with the AO classification. It's pretty intimidating when you look at it, but it kind of classifies it into 3 different categories: compression injuries, distraction injuries, translation injuries. There's an algorithm here, and then the modifiers that we talked about earlier. It provides a detailed description of the injury morphology for primary evaluation using CT scans with or without MRIs. Strengths, obviously more descriptive reliable, and then correlates better with surgical management. Um, and then offers separate codes for injury morphology and neurologic status. Obviously, the weakness is it's a lot more complex than the TLIX classification. This is a paper. Essentially, the study calculated TLIX, modified TLIX, and then the AO classification scores were calculated on 476 patients using CT, MRI, and the documented neurologic exam. Treatment recommendations were compared with treatment received. The researchers found that all three systems performed pretty well in terms of classifying the thoracolumbar injuries. However, the modified TLIX demonstrated improved sensitivity and accuracy compared to the original TLIX, and then higher accuracy and specificity than the AO classification. The sensitivity of the AO classification was higher than of TLIX, but it demonstrates that all three can be used. The modified TLIX is a little bit better. And the modified TLIX is essentially they added height loss greater than 50% or central canal stenosis greater than 50%. And then 2 points were added onto the original TLIX score to create the modified TLIX. But as we talked about last week with Dr. Mundis, which I think he got the movie wrong, it's Dirty Dancing. Nobody puts baby in a corner in terms of classifications. So why?
Okay, I'm okay with that error.
So why minimally invasive surgery? Obviously, we talked about it reduces approach-associated morbidity while obtaining similar outcomes as traditional open spine surgery. The principles we touched upon last week in Journal Club as well, neurologic injury, prevent further neurologic damage, stability, and correct post-traumatic deformity. And the next thing I thought was pretty important in terms of minimally invasive spine surgery was damage control orthopedics. In terms of damage control orthopedics, this chart I got was for viral infections, but we can apply it to trauma as well. So the original insult itself, you can see that the inflammatory response happens, but you want to prevent essentially the second hits, which can actually bring the patient up into serious systemic inflammatory response that can complicate the course of their treatment with ARDS or multi-organ dysfunction syndrome. So obviously, compared to open surgery, we're reducing the morbidity due to the approach and possibly length and then blood loss to prevent this. And there is nuances to spine because of neurologic status, but I think that this is applicable in terms of minimally invasive spine surgery. This was just a quick review. This paper looked at pH, base access, lactate, complications regarding end complications being ARDS, pneumonia, and DVTs. Lactate was the most specific predictor of pneumonia. Chest injuries were strongest independent predictor of pulmonary complications. And then early appropriate care protocol. You want to fix unstable fractures within 36 hours as long as the lactate is less than 4 and base access is greater than negative 5.5. So minimizing the physiologic burden. This study compared two minimally invasive techniques treating thoracolumbar burst fractures with posterior ligamentous complex injuries, posterior pedicle screw rod fixation, percutaneous, and then the paraspinal fluoroscopically guided pedicle screw rod fixation. The study found that the percutaneous pedicle screw fixation was associated with less blood loss compared to the paraspinal, shorter surgery and hospital stays, less pain and better recovery, which demonstrates that minimally invasive surgery can reduce the time of surgery, blood loss, and hospital stays. And then what about infections? Um, this paper supported that minimally invasive surgery can also reduce infections pretty significantly in this one. So this was 1,213 patients. The region of surgery was in the lumbar region for 80% of the patients, cervical and 12%, and the thoracic and 3%. Decompressive procedures were the main procedures, about comprising of 78%. And what they found was 3 postoperative surgical site infections were detected, 2 superficial and 1 deep. The procedural rate for a surgical site infection for simple decompression was 0.1%, and 0.74% for fusion fixations. The total surgical site infections for the entire group was only 0.22%. So the incidence of surgical site infection utilizing minimally invasive spine surgery can be less than 1% after decompressive procedures. And compared to the traditional open procedures, it can go up to some papers greater than 10%. So this kind of shows that minimally invasive surgery can reduce infection by almost 10 folds, which is pretty significant in terms of our sick trauma patients. Again, the types of MISS that we're using depends on the type of injury. Neurologic injury we talked about, and then we'll go into surgeon expertise, and then patients' comorbidities and body habitus. And do we need to fuse? And on the right-hand side there is types of MIS procedures that we can do in spine. So I think the most common minimally invasive surgery is percutaneous pedicle screws. This research paper was a meta-analysis that reviewed 9 studies comparing percutaneous screws versus open pedicle screw fixation in the thoracolumbar fractures. Basically, the key takeaway was that percutaneous pedicle screw placement had shorter operative times, better Cobb angle restoration, less postoperative pain, and a lower screw misplacement rate compared to open. So it is safe and effective in terms of comparing it to open. This is another study. Pedicle screws were inserted from T4 to S1, most commonly at L4, L5 for spondylolisthesis. The complication rates that they found was out of 424 screws inserted, only 9% were misplaced. The vast majority of them being grade 1 violations, which were breaches less than 2 millimeters. And then they only had 0.5% of screws that had severe complications, which they considered like a grade 3. Compared to open techniques, percutaneous approach demonstrated a lower perforation rate compared with traditional open methods, which reported a higher complication rate. Again, this study demonstrates that minimally invasive surgery is safe and effective, and possibly more effective than open methods with lower complication rates. And next is navigated and robotic cases. I kind of went into this because Dr. Stefan also uses navigated robotic methods. Obviously, you get guidance in real time feedback. It's accurate, and then robotic assistance can help with stability and precision as well. And then in terms of operating time, it's less, but you kind of pay for it in the front end with the planning and preparation of robotic cases. And then this paper here, what they did was focused on robotic navigation for a single position lateral lumbar interbody fusion with percutaneous pedicle screw placement. What they found was 98% success rate in terms of the pedicle screw placement with no revisions or complications. related to screw placements with their robot guided pedicle screw placements. Next, this one was a study that eliminated the need for guide wires or K wires, nitinol wires for placing in pedicle screws. It was 140 patients, mainly considering mainly revolving around degenerative disease and deformity, but they also had trauma. They found that there was a 98% accuracy rate for screw placement within the pedicle and a low complication rate. Less than 1% experienced a screw-related complication, which they considered a medial breach. This suggested that navigated percutaneous pedicle screws with navigation can be safe and effective as well, with high accuracy and low complication rate. Fusion versus instrumentation. This was a paper, and the imaging on the right shows a non-fused case for trauma, essentially just posterior instrumentation. And this paper demonstrated that, or was looking at both fusion and non-fusion of burst fractures. And what they found out was that radiographic and clinical outcomes were no significant difference between the two. But they also found that the non-fusion group had better angular change, correction, and intraoperative blood loss. And obviously, OR time is less if you're not going to fuse. And this was you can also, one of the papers I saw, you can actually put pedicle screws into the fractured affected vertebrae if it allows for more biomechanically stable fixation. In terms of surgical techniques, there's also the extreme lateral interbody fusion. This was a meta-analysis that reviewed 12 studies on extreme lateral interbody fusions for various spinal conditions. And the key finding that they had was they had significant improvement in pain and disability scores, as you can see on the chart there. Increased disc height and correction of lumbar lordosis, and a fusion rate at 12 months ranged from 85% to 93%. The most frequent complications being neurologic conditions and hardware failure and transient pain, obviously going through the psoas muscle. And then obviously another advantage for this would be you don't need to have an approach surgeon, as with other interbody fusions. So what are the downsides of minimally invasive spine surgery? There's a higher complication rate initially. So this paper looked at how many cases you would need to actually become proficient. And the researchers found that there was a higher rate of complication during the initial learning curve for minimally invasive surgeries in the thoracolumbar fracture category. And they found that particularly in the first 30 cases. So there's a steep learning curve in terms of minimally invasive spine surgery. But they found significant improvement after the 30, and this kind of harps on the importance of training and being comfortable with the type of surgery that you're doing. Another one is radiation exposure, especially the spine surgeons. With the limited visibility with open, you're relying a lot on fluoroscopy. And this paper kind of just, I'm pretty sure everybody in this room knows, the radiation exposure to spine surgeons are significantly higher compared to other orthopedic surgeons. And minimally invasive procedures can be even higher than traditional open procedures. This is pretty interesting picture here. I think it explains a lot. Two things. One is if the patient's weight is greater, so the bigger the patient, the more radiation exposure that you'll have. And then also, as you get further away from the patient, the less radiation exposure you're going to have. So you want to aim at least 35 centimeters away from the field to reduce your risk of exposure. And then this was a recent case that Dr. Stefan had in terms of spine trauma that he utilized minimally invasive spine surgery for. This is a 19-year-old male involved in a motor vehicle accident. He was in a rollover, 50 to 60 miles an hour, restrained rear seat passenger, and complained of low back pain, subjective weakness in lower extremities, and had no numbness or tingling, no loss of consciousness, and initially presented with a GCS of 15. Past surgical history of XLAP for stabbing and social history of a tobacco and marijuana user. Physical exam, he had 4 out of 5 strength bilaterally for his extensor hallucis longus. Sensation was intact, light touch throughout, and rectal tone was intact. Labs, lactic acid was at 4.3, which is right at the cutoff for our damage control orthopedics. And then also positive for fentanyl and negative for alcohol. Fits the category for a typical trauma patient. And in terms of, this was the initial AP radiograph in the trauma room for his pelvis, which demonstrated a minimally displaced comminuted right ischial fracture and some disruption up here near the sacrolumbar junction. That's kind of hard to tell with his sacralization of the L5 vertebrae. So a CT was performed, and we found that he had an L5 burst fracture with significant stenosis of the spinal canal and left-sided L1 to L4 transverse process fractures. MRI here demonstrates that retropulsion into the spinal canal. And then on the sagittals demonstrates that all 3 columns, the anterior, middle, and posterior columns were all disrupted in concerns with his L5 burst fracture. So the next day, Dr. Stefan and Yusuf took this patient into the OR, and he received a L3 to pelvis percutaneous spinal instrumentation. And these are radiographs or fluoros intraoperatively. Flat plates post-op that demonstrate restored lordosis and safe instrumentation regarding his L3 to pelvis percutaneous instrumentation. And post-op, the patient had his pain well controlled, regained his motor sensation to bilateral lower extremities, was ambulating with physical therapy, his lactic acid normalized, and then eventually discharged home on post-op day 6. So in conclusion, minimally invasive spine surgery is safe, effective treatments for spine surgery, and still incorporates the principles in terms of achieving the principles of preventing neurologic injury, stability, and correction with regards to open surgery. And then there's a reduced morbidity, which is pretty important in terms of our trauma patients, because many of them are very sick, or polytrauma patients that relates into damage control, orthopedics. So smaller skin incisions, less invasive, reduced surgical trauma, blood loss, and needs for transfusions. We've demonstrated that it can also lower infection rates, and then obviously preservation of muscular anatomic structures, which can lead to faster recovery time and minimizing that second hit. And then lastly, make sure you do the surgery that you're comfortable with. As we discussed, there's a steep learning curve with minimally invasive spine surgery. And then obviously because of the limited visibility, you are introducing yourself to more radiation exposure. However, less radiation exposure if you're doing navigated robotic, but at a cost to the patient, they're getting more radiation exposure in that sense as well. And these were my references.
Nice. So a couple comments on some of the words you used.
Okay.
Just realize that there's implications with it. I think you said a few times it's as effective. Should be down here. Which may not be the right words.
Okay.
So just be careful, especially with boards. If you say it's that, if they ask you a question, what's it safe as and effective? Well, the studies don't really show that. They just show that you could accurately place a screw, for instance.
Yeah.
And say that's effective.
Okay.
And then I think you just said that. Steven's on. He won't mind me saying it, I'm sure. But like, you never store osmosis on that case.
Yeah.
Like that guy's super flat from 4-1.
Mm-hmm.
So just be careful on you're able to successfully percutaneously fix that.
Mm-hmm.
But that guy's like flat as all get out. Now he's young. You'd probably be fine with it for a temporary period. Take the screws out at 6 months, and then he may on his own arch his back up normal. So I do think that's one of the downsides of these operations is that you don't have the ability to manipulate the tissues as well.
Okay.
But I still think it's it's a big game changer for us, right?
Yeah.
Doing an L2 to pelvis open is a very different operation than doing percutaneously and being able to get away with it. So if you think about it as an internal brace, if you give someone flat, if you give them flat posture for 6 months, probably not that big a deal when they're young and healthy and but when they're young,
Yeah.
able to recover, versus when they're older and you're trying to fuse them,
Yeah. One thing
Hey, Greg,
on that case too.
real
is that
quick
we
on
were
that.
doing-
On that. Okay, good.
I was just gonna say we were trying to correct that lordosis, but because we were doing it MIS, you can only get so much, I think, correction, through pulling on the screws and stuff like that. And we're only down, and we were relying a lot on S1 to really be a powerful screw to kind of correct the lordosis. It was just very challenging. So that's kind of another limitation that we definitely encountered. It's great. You get soft tissue sparing, and as Dr. Monis alluded to, hopefully he'll correct his posture a little bit more, but your hands are very tight in terms of or at least what we experienced, our hands were very tight in terms of what we could actually kind of correct through.
Because you had collapse of the body, which means you're losing biomechanical ability to change,
Right.
Because now your SPs are bumping up against each other. You have collapsed bone, only so much you can do, right? If you had a pro axis, it would be cool to see it.
Well, we tried that. We tried that, but he didn't get much even by the way of that too, which was interesting. We thought it got a little bit better for sure, definitely from when we started to where he finished. But
did you guys use polyaxial screws?
That was really my next point, Bob.
we did, yes, we did.
Yeah,
So
so,
then
you're not going to
screws.
expect a ton there. You got to be
Yeah.
able to monoaxialize at least
Oh,
the
yeah, okay.
production screws.
Yeah.
And you don't have to use them everywhere, but you kind of have to use them in that case, you'd use them at 4 and S1.
And
So
one, yeah. So you can really, yeah.
Otherwise, your rod just goes to the shape of the
Mm-hmm.
polyaxial.
Your screws follow the shape of the rod,
Yeah. Yeah.
right?
Yeah.
Yeah, the screw heads.
Also supine.
But thanks.